Our next speaker is Dr. Don DeZong. He is the Director of Women's Cancers at the Lifespan Cancer Institute, Director of Medical Oncology at Rhode Island Hospital. We are honored to have you with us today. Thank you so much.
All right, thank you very much for having me. It's an honor to present for the Oishi Symposium. I was asked to do a presentation on social media and research, and I think this is actually a really great group to present this to. For so much of the work that our nurses and the CRAs do, it's almost a lot of it is what you have to give back to the site. I want to encourage all of you to look at this presentation and walk away from it thinking, well, this is how I can actually contribute in a different way in proposing an idea and in actually looking at that data and potentially even publishing that data alongside your investigators. Because when it comes to social media and digital health research, you don't actually need an MD by your name. All right, so what I'll cover right here is what do I mean by social media. We know that SWOG was the first of the cooperative groups to have a digital engagement committee, and I was asked to chair. I'm really grateful for that opportunity. But social media is a very big vacuum for a lot of people, so I want to be very specific about what I mean by that. The second question is why you should actually care about what social media is in your capacity as a SWOG investigator, CRA, and research nurse. The third is what can possibly be gained by exploring social media. And the fourth is the more practical question of how exactly does one do this. The take-home points, social media is here. The digital age is upon us. There are conversations about cancer that are ongoing, whether or not you realize it. Your patients are talking to each other, and they are not talking to each other in your cancer center. They are meeting online in various communities, especially if they have a rare case and especially if they have recurrent disease. They are finding those resources outside of your center. You need to know that. Social media represents an opportunity to listen to what's being said, to learn about experiences that you may not be told about, but more importantly, it's to engage. It's for you to impart the wisdom you have from the seat you occupy. That's a really important voice that so far is still missing. So social media is mechanisms by which communities form, and they form by shared interests. This is a social family, and they are there because they share a mission, a drive, a condition, and they're looking for similar-minded people. These are the technologies that allow them to gather, to communicate to each other, and to communicate to groups that they may not even know about. The major social media companies I'm sure you're all familiar with, Facebook, Twitter, for clinicians and professionals in and outside of medicine. LinkedIn is becoming far more important, almost 500 million folks in that. Doximity is another physician's social media platform. They are trying desperately to get into CME activities on Doximity. The importance for all of us who are ranked at US News and World Reports. This is how those ranks are formed. Your physicians are queried to see what are the top 5 programs in the country. This is one of those mechanisms. Snapchat and YouTube being the largest video sharing website. Did you know SWOG has a YouTube channel? Did you know the Oishi Symposia is on YouTube? It is. Other platforms that exist are blogs. This is the content where everyone publishes their own thoughts. It's completely unfiltered. There are claims that are made that may or may not be verifiable. If you're asking yourselves, is this how my patient found out about drug X? Certainly it could have been from a blog that looked for all intents and purposes like a news article. It is also about opinions. There's also multimedia sharing. I have a column with ASCO Connection that I publish quite frequently with. Kevin MD is a data aggregator. So Kevin is a physician in New Hampshire, And he has a team that looks at blogs that are put out on medical content in the United States and elsewhere, and he aggregates them into his site and is now sponsored by MedPage Today. So social media continues to increase. There's a merging, I believe, of medical sciences and digital marketing that I think we all should be aware of, and that we should be aware of it because social media, when I send that tweet or I write a blog, I know my audience isn't local. It is global. So what do we know about the global use of social media? It is in the billions, no matter what the formulation here. And it's going up each year in terms of internet users, social media users, unique mobile users, and active mobile social users. These are important figures to understand, especially for those of us in this room who are dedicated to clinical trials, because it's all about patient outreach. Where are those patients and how do we get to them? If you're assuming that patients in rural areas do not have internet access, you might be right. But we also know that patients in rural access are increasingly smartphone owners. So it's not that they don't have digital access. The access you might be thinking about is incorrect. But the other thing about social media use is that it's worldwide and it's growing everywhere. So as we look into our Latin American initiative, as we look at going global with our mission, it's important to know this represents an opportunity to reach investigators in other countries and their patients. But it's important to note that if you put all your eggs in one proverbial social media basket, you may or may not get anything out of it. This is a list of all the social media channels that are currently present. If you'll see, the largest by far is Facebook, followed by YouTube. I am a personal Twitter user. That is very far below, where there's over 2.1 billion Facebook users. 300 million worldwide are using Twitter. So I know when I tweet, I'm reaching an American audience, not a global audience. And that's fine from what I want to do if I'm trying to enroll a clinical trial within the US. So do not ignore social media. We in SWOG cannot afford to ignore social media. Adopting social media doesn't mean you yourselves need to adopt every single social media platform. Understand what you want to gain from it. Choose your platforms wisely. Why should you care about everything I just said to this point? It's here, and this is work that's done from the NIH. If you ask how many Americans are looking at Dr. Google or the internet first for medical information, that continues to increase. So all of our work in education, in information that we're working on, it's so important. When patients develop a condition, including cancer, they're not calling Cancer Center of Excellence X, Y, or Z. They're looking on the internet. They're looking to see what can they find out from the comforts of their own home and from the privacy of where they sit. But who do they trust? They don't trust what they're finding on the internet. They still trust clinicians. This is a figure from cancer.gov. 90% of those folks finding information trust the information coming from physicians more than they do from the internet, more than they do from newspapers or television or radio, by far. So we are still important. In the era of social media, our voice, what we say, carries weight. That does not mean patients are making decisions with or without us. They are making decisions based on what they're reading, even if they don't trust it. So what proportion of patients say that social media impacts how they deal with their health? 4 in 10. Of younger patients, how many of them trust what they're reading in social media? 9 in 10. What proportion say social media impacts who they go to as a healthcare provider? 4 in 10. And it's likely that these figures are increasing. Your voice, your presence on social media can, like it or not, automatically provide you weight. So the bottom line, we need to care, SWOG needs to care, your institution needs to care, your physicians need to care for 2 very simple reasons. Your patients are online, and more importantly, you as a clinician are likely online, even if you don't think you are. So from that very sobering talk, let's say, what actually can you accomplish using social media in the era of clinical research? Recognize that social media is an unfiltered look at the cancer experience, all right? It's basically the questions you've always wanted answered in a non-filtered way. The perspectives are not limited by where you live. These are global perspectives. These are national perspectives. You can use them strategically. If you're asking a question and you need background, you can go to PubMed and get that literature, or you can do a focus group on social media. Generate what are the needs. That can be used as background for any grant applications, but more importantly, it is a place to grow that advocacy and even fundraising for causes important to your centers and for your causes. The largest focus group in the world is actually found online. So just as an example, this is work that I did with Teresa Hagen, who's at the University of Pittsburgh, a nurse doctorate. And we were looking at interventions to improve survivorship in ovarian cancer. This is an important topic because most women treated for ovarian cancer don't see themselves as survivors. Survivorship care plans are almost synonymous, as a gyn-onc with my hat on in medical gynecologic oncology. Survivorship care plans speak to women with breast cancer. They speak to men with prostate cancer. They don't speak to women who have an 80% risk of relapse within the first 3 years. So we wanted to know, what exactly are the survivorship needs for women with ovarian cancer? We went to Twitter. There is a social media community, hashtag GYNCSM, the Gyn Cancer Social Media. They have a tweet chat that happens every month. And we partnered with the leadership of GYNCSM, which is multidisciplinary. There are physicians, there are nurses, there's a patient advocate, as well as a woman living with ovarian cancer who moderate GYNCSM. Then we went to national collaborators and said, we're going to do a tweet chat on survivorship. Will you use your handles to promote it? The Ovarian Cancer Research Foundation Alliance, Society for Gynecologic Oncology, Foundation for Women's Cancers, the National Ovarian Cancer Coalition, all supported this tweet chat and publicized it on their Twitter handles. To do it, we came up with 5 questions, T1 through T5. These questions were things that Teresa and I wanted to know. These were not user group focused. This is the questions we as investigators wanted to know about for our applications. What does survivorship mean to you? What is it to be an ovarian cancer survivor? Do you use that term? And if you don't use that term, what do you prefer? These are specifically listed as T1 through T5. And when folks answer these questions, they are answered as A1 through A5. Because Twitter is live, but people can look back to see what did they miss, and they can answer questions even as you pass through it. That's the difference between doing a focus group on Twitter and do it online. You do not need to direct people to prior questions. They can find those questions, and they can answer those questions when they find it, not when you've moved on. So we did this tweet chat. We had about 380 unique tweets, and we had 43 people participate in 1 hour. That was an average of 9 tweets per person, And in the following 24 hours, there were 60 tweets added on. So this conversation, even as it ended, continued on Twitter. This is a word bubble. This is the frequency of words that came up in our tweet. Cancer survivorship, very large there. To help, joining, trying, mental. These are also some words that came in afterwards. I thought this was the most interesting thing we did. We did a sentiment. Sentiment in orange is more negative. Sentiment in green is positive. Just as a gestalt, even in an era where women do not see themselves as survivors the way it's used today, women with ovarian cancer have a fairly positive view of being an ovarian cancer survivor. They feel great, they feel good, they feel glad, they care, they have support. It's fairly positive, which I thought was surprising. What did we learn? We learned that there's a lack of support as women transition from cure to recurrence. We learned that the physical and emotional needs of this population is not being met by clinicians. We learned that women with ovarian cancer are navigating this field independent of us. And I think that the navigation speaks towards women being proactive. So what do they want? Where did this point us? They want resources. And if you think about it, those resources actually exist. So they're not finding those resources, or they're not finding the resources they need when they need it. We know care plans, as devised by ASCO, have no use for this community. They are not appropriate for this population who face a high risk of recurrence, because this population wants those care plans to address what happens to them after they relapse. This is sobering, and it tells us there's work to be done, but it also tells us care plans can be useful, and it points a way forward. So in all, I think it was a good 1 hour's use of our time. Indeed, the NCI also recognizes it. I will point you to 2 grant opportunities that you can take back to your teams, both of them in social media, and both of them looking at studying cancer communication in this new media environment. It is a wide open space, and we need best practices. We need data on what works and what we mean by it when we say this works. Twitter, I will focus in a little bit more because, again, for US medicine, this is a platform that a lot of us use. Twitter is big data. So we talk about big data in terms of genomics and proteomics and all of these genetic data sets. Think of Twitter, think of tweets as such a data set. Tweets are grounded in an experience by a user who is tweeting from a specific location and tweeting a specific sentiment. That tweet is composed of language and context, and it's typically not an isolated event. So these 2 researchers in the social sciences asked, what public health information can we learn from Twitter? This kind of work has been done in the past. You've probably heard about with Google search being used to identify flu incidences. So they came up with something called the alignment topic aspect model, and it was really looking at those tweets in a very basic level to see how a user is expressing illness and ailments in their tweets. And so for each tweet, the assumption, the hypothesis, is that there was a latent ailment behind it, and that ailment had a distribution over these health-related tweets. So the ailments are listed here on the top, all the way from allergies to cancer, obesity, and then a dental word. But if you look at the priors and prior frequency of the words that seem to track with cancer, for example, breast cancer was tracking. But look at the words and the symptoms and the treatments that were coming in with cancer, aligning with the ailment of cancer. Prayer, mom, pain, sadness, surgery, hospital. Okay. What they then asked is that they have all this data on symptoms, S, treatments, T, and they said, which one of these correlate better? And the higher the number, the better the correlation. And they found that in their modified model, which is ATAM+, treatments align better with diseases than symptoms, which may make sense. Pain, very general. It could mean anything. Chemotherapy, pretty specific. Probably aligns with cancer. They then did this, they asked a question of whether they could associate with these tweets in a geographic way. And what they found was a correlation here between certain risk factors and the ailments that represent them. Tobacco use and cancer had a very high association. Obesity and exercise, there was a negative association. So where the risk factor was obesity, or where folks were tweeting exercise as an ailment, all right? The risk factor was obesity, okay? So again, very interesting correlations were being found in this model. They looked at how does Twitter help us analyze symptoms? Again, the symptom tied to an ailment, the lower the number of entropy, the tighter the association. Mood had a low entropy, was tying with depression. Tumor had a low entropy, tying with cancer. But if you look at pimples, high entropy at 0.72, tying with depression, okay? Again, some novel things not outside of our field per se, but again, just a sense of what you could potentially look at. What about medication use? When I saw this, I was thinking about, can we track opioids in different manners using Twitter in our population? If you look at codeine, it had a fairly high entropy, so very loose, but it was tracking with just the presence of the common cold, dental issues, headaches. Whereas something like Zyrtec, if people are tweeting about Zyrtec, that was very, very closely tied with an allergy. So again, it is possible to look at a big data set to find trends and associations. This should not be lost on us. This is an important aspect of the work we might be able to do. The issues are here. Twitter data is US-centric. I said that before. Twitter data also represents a younger population who's tweeting, and it is not an automatic function of Twitter to tag locations onto tweets. So if you try to do that data, where you want to see how does the experience of breast cancer differ from the West and the East, you will not be able to use all the data in Twitter because you have the ability to turn on and off geotagging. Finally, tweets do not necessarily represent a first-person experience, and it also does not represent your lived experience. I could be tweeting about my mom's breast cancer and her pain. It may not be me. So at the end of the day, even with Paul and Dresde, of over 1.6 million tweets they evaluated in their data set, they could use only 8%. All right. So this is an issue that we have to face. I think we'll be able to use this a little bit better as Twitter gets morphs into something. Who knows what that's going to look like? But it is possible to mine Twitter. It is in its infancy. So this is a place where like-minded folks can do multidisciplinary work in analyzing Twitter for the purposes of oncology, clinical trials, and cancer care. It requires collaborations, but I will tell you right now, it does not need to be an MD to lead as a PI. It has the potential, though, to inform oncology beyond treatment, and I think this is a huge potential. Think about the experience of toxicity reporting by our patients, which I think will get better with more PROs being incorporated. Recognize, and this came out in a forum that the NSI sponsored on the crossroads between social media and clinical trials, and I mentioned Dr. Denikoff, who helped put that together. Your patients may be talking without your knowledge about their clinical trial experience, trying to see if their symptom complex means they're on drug or placebo, without telling us. They may be looking within their own communities about, is anybody else having symptom? Why? What worked for you? And not telling us, okay? Twitter may be that way for those connected patients to be doing that kind of outreach, okay? Because for now, in digital engagement, it wants to approach this in a way that addresses best practice and expectations of patients on clinical trials. But this is a black box for us. And I wonder if Twitter can point in a direction that can give us some more information. Finally, in terms of just the practical aspects of using a Twitter database versus a Facebook database, Twitter data is publicly accessed, okay? So once you tweet, it's in the public domain, all right? As opposed to Facebook, which theoretically has a privacy component. So I hope I've convinced you that this will be a worthwhile opportunity for all of us. And I would encourage you to get involved in social media, even if it's just to dip your proverbial toe into that pool. Because you are online, as a clinician especially, even if you think you are not. If you don't believe it, Google yourself. Google your PI. Google the docs you work with closest. This was a while ago. I had 470,000 results with my name. This was a couple of years ago. It's a lot more now. I'm just kidding. Importantly, we in this room have no control with how this information shows up on the web. All right? You have no control what order this information appears on the web. It's by the algorithms of the social media companies that say how these things float up. You can certainly buy space so that your profiles are preferentially appearing, but that assumes you have a professional profile you would like to come up first. So the best advice I have for all of us is to adopt dual citizenship on social media. I think it's very important. It's a way for you to grow yourself professionally on this space while giving you a maintained private component. Examples would be to use Twitter professionally and only to use Twitter professionally, and maintain Facebook for your own personal and confidential things you share with family and friends. This is actually supported by the American Medical Association to separate professional and personal, totally fine. Recognize that even as you do this, all social media should be thought of as public, okay? Some tenets for the clinicians in this room, which is all of us: be thoughtful when you post. You represent professionally not only yourself, but your institution. Be transparent, even more important today, given certain current events. Describe conflicts of interest. Be clear. If you're commenting, speaking for your own opinion rather than your institution, bring that out. Be smart. Don't post anything you might regret later. And my 3 tenets there: never post when you're angry, inebriated, or sleep deprived. That's when people get into trouble. Maintain your boundaries. And I think this one is, I can happily go into it if you want, but my opinion, it's not a good idea to friend or follow patients that are under your care. More importantly, you have to protect patient confidentiality in everything you tweet. Recognize that none of our social media spaces are HIPAA compliant, and recognize that professionals have been sanctioned for social media use. Some of it is because of misinformation, calling yourself a surgeon when you're clearly not a surgeon, breach of confidentiality, and inappropriate communications. If a patient of yours sends you a tweet asking, what am I going to do about my condition? That's actually okay to respond to, because you did not breach confidentiality. Okay? The patient posts her information, his or her information. She is divulging health information, but it is her or his prerogative to do so. This is something that we created through the American Society of Clinical Oncology, about 10 tips. Get involved, engage often, always identify yourself. So this goes into when you produce an avatar, use your name, especially if it's going to be something you do professionally. Protect confidentiality and privacy always. Contextualize your activities, avoid impropriety, give credit where credit is due, be professional, separate personal from the professional, and understand your institution guidelines regarding social media use. How does one do this? Try out multiple sites. Go ahead and sign up for Instagram and Snapchat and Twitter and Facebook. There's never an obligation to stay with anything. Find the medium that you are comfortable with and call it a day. Pick a username, again, that identifies you, and then you lurk. Lurk is just seeing what this forum is all about. And how does one lurk in oncology? You follow certain people, see what they're posting, commenting on, see what's on their timeline. You follow certain hashtags. Hashtag clinical trials, hashtag SWOG, hashtag GYN-CSM or breast cancer social media, BCSM. See what information is filtering through the social media fog to find the information you think might be worthwhile for you. If you want to try this, one opportune way to do it is through the ASCO annual meeting, ASCO 19. Even if you're not there, there is a bunch of us who tweet ASCO, and you can follow a lot of information, multiple tumor types, multiple sites, at the comfort of your own home. You can comment on them or you can follow them, but I think the most important thing of doing that, you get the perspective of folks who are not oncologists and what they think of the data that is being tweeted. That perspective has probably been the single most important lesson for me in social media engagement. Here's a couple of hashtags you can use on Facebook to filter Facebook for public content. You can also use it on Twitter. You can also use it on Instagram. So have I convinced you? Probably not. These are the sobering figures on social media and clinicians. If you look at whether or not people contribute, seek, or explore, look at the never or rarely. A lot of folks aren't on social media. And if you look at on the right side, not aware or will never use, significant proportions of our community will never use YouTube or Facebook, Twitter, LinkedIn, or look at blogs. This is despite some data showing that about a third of patients, or a third of our group feels it's essential, beneficial, and that social media engagement returns high use information, more so than those who see it as a waste of time. And if you ask patients or ask clinicians who are on social media whether their use of social media influenced how they practiced oncology, of us who are on social media, it absolutely has made a difference in how we treat our colleagues and in how we treat our patients. The barriers are numerous, so it's no value here in terms of academic merit. It's considered a waste of time, especially since we are on email all the time. It's a huge risk. You just told me that people are getting sanctioned for social media use. Why the hell would I do this? And when we all want to unplug, I'm actually telling you to plug back in. You know, he's just, okay, just, all right, yeah, I know everybody agrees with that. So the question is, how do we engage you? How do we engage our peers? First off, a group of us want to provide data that this can have professional advantages. We want to see, I want you to look at social media engagement as an altruistic proposition. That although you yourself may not gain anything from it directly, providing your input, your opinion, pointing people to right directions helps a larger community. You can also engage reciprocally, all right? You see someone stressed from cancer and you respond to them, you can actually make the difference in one person's life at that specific time. And I want to nurture collectivism, that all of us in a shared endeavor, which is social media, just like all of us engaged in SWOG, are trying to create something better. If we all engage in social media, we could create something better for U.S. oncology healthcare. This is where something called the Collaboration for Outcomes Using Social Media in Oncology will hopefully step in. We call ourselves COSMO. We are representatives from all parts of the U.S., from the East and West, South, and also the Central U.S. We are hoping to forge clinical collaborations and define best practices for our peers. We want to conduct outcomes research to answer questions of whether or not this is truly of benefit, and maybe one day do empiric research again on social media engagement. Cosmo has published. So Matt Katz, who's a colleague of mine in Massachusetts, has done the report of hashtag for online communication. That went to JAMA Oncology. Deanna Atai, who's a breast surgeon in California, Mike Thompson, who's in Wisconsin, Mina Sedrak, who's a Coltman Fellow here, and others have published position and opinion pieces about how oncologists can use social media, why you should look at social media, and the potential advantages and disadvantages. Dr. Hagen's work I referenced earlier was a product of Cosmo analysis and also helped in the writing of that paper. So stay tuned. We do have a username on Twitter if you want to look at that. But in summary, social media has changed the way patients are approaching us in our cancer centers. It has changed the way providers, those of us who have explored social media, it has changed how we communicate with our patients. It has changed what is coming to your attention online. If you ask any patients engaged online, what is the single most important thing they look for? It's the clinician's voice on social media. Again, it points out lots of information out there. In fact, they will search for that information first. But the reason our patients are providing us with reams of paper they found online is because they want to know, what do we think? And that is the same experience online. So we can change the way healthcare is communicated in this country. We can do it using channels that already exist in digital health. In an era of fake news, we can actually point people towards reliable sources. But for those of us who want to learn more about all of this, this is big data. It's big data in its rawest form. It is unfiltered, and a lot of times, you can't even tell who's posting it, which is a challenge So it's completely unfiltered. We can learn what's important, though, from the folks who are impacted. We can relearn how to talk to patients in several communities. It can inform your research, and it can help you generate new questions. So one of the things that have come to my attention recently through work done from an undergrad at Brown was the going flat movement in breast surgery. This has not received any publication in an academic journal. There was one paper on women choosing not to undergo reconstruction that was in Cosmo. This woman, in her junior year coursework, did a focus group study of 2 Facebook groups on the going flat movement. And we're going to publish her data. Because if, as we sit here as advocates in the breast cancer community, we want to know, we want our patients to know reconstruction is an option. Reconstruction will be paid for. Reconstruction is your right. But how often do you hear, and if you don't want to do that, that's okay? This is what this group is telling us. The option of going flat was mentioned as, oh, okay, you can go flat. No pictures of what going flat might look like. No pictures of what the expectation is if you do a bilateral mastectomy. No understanding of what they thought they were going to look like versus what they ended up looking like. So a lot of work is being done on this community that even 3 months ago, I had no idea existed. So thank you for having me. I hope I challenge you to sort of explore all of this. This is my Twitter handle and my email address, and I'm happy to take any questions. And you should follow me on Instagram. It's the same amount. I post 3 things on Instagram. Professionally, what I'm wearing. So this is all that. I post travel that I've done, and really great pictures of my cat. So you should look at that. Okay, thanks. Thank you very much.